Thanks a lot. It is a great pleasure to stay together with you today. I'm a clinician mainly. Even my hospital, we have for sure research. My hospital, it has 140 years, and we had the first older journal orthopedic and trauma. Nowadays it's different. It is site in the middle of Milano. I'm president of European Society, Tissue Regeneration, Orthopedic and Traumatology. We founded together with some friends, Professor Giannudi, Professor Beguet, Professor Schmidmeier, and nowadays we represent 1,400 universities all over Europe from 32 countries, and some others ongoing in the membership. It has been officially recognized by European Federation of Orthopedic National Society, and we have a special network with many activities, and mainly we have this web. So we can check all the activities of Europeans in this web. So my speech is to speak what's about the risk. Who is at risk? Because this is a problem. We have to focus on the patient at risk, because from a clinical point of view, we have to take care of difficult pathology, but we have to consider the patient not only because pathology, but because a person. That's the reason because we have patients with reduced intrinsic bone healing capacity, and we have to point out the comorbidities represented from the patient. So we have developed this paper about the classification, but because it is based on the risk factor, general and local, because we have different kind of risk. Speaking of general comorbidities like diabetes, diabetes is a very hard, tough pathology when we have to approach something in orthopedic and trauma. Bone fragility as well, because gene mediate, it represents something very difficult, like in this case, very tough to treat. So we had to improve in such a patient, perhaps our new technologies. And drugs, what to say about drugs? Because the non-inflammatory cases we have to approach by using different drugs, but we have to know exactly what they represent in the general mix of the patient. Local, many problem. When we approach polytrauma, for sure we have to consider if we have to approach multifracture or polytraumatic patient, and we have to follow an algorithm of treatment, for sure, to perhaps reach a reasonable healing. Come back to the beginning of my speech. I would like to say the failure, it comes and differently from two pipelines, and the sepsis is side effect, and at the end we have the failure. But the failure we have to interrupt, because we have to interrupt the pathological chain. So we have to use this algorithm to prevent, but when we have already the damage, we have to consider it. So we have to come back to understand the complexity represented from the patient. It means to know the risk factor, the classification, new kind of a classification. This is the main topic of my speech, and to reach an algorithm of treatment based on a ladder strategy. How to approach fragility, fracture, or critical size of failure? We have to interrupt the pathological chain as well, and so we have to point out, to apply the algorithm treatment. What means? So we have some cases like this with a large defect in acute trauma and spontaneous healing within 12 weeks. As well, we have many patients well treated without any healing after longer term. So we had to discuss about the gene profile because this is really new. And actually, the classification based on morphological aspect are unable to say to us, to predict the healing processes. Certainly, the X-ray and CT scan, they cannot estimate the cellularity, the gene expression, and the chemical environment. That is because we developed, together with a friend in Leeds, Professor Giannudis, we developed this new classification. Actually, it has applied in 14 countries all over the world. We had already 12 reviews. This is one in orthopedics. And we have checked more than 1 million cases by using this approach in classification. The classification is based considering not only the pathology, a lesion, pathological lesion, but all the patient. It means all the comorbidities represented for the patient. This is really new. So we are able to distinguish 4 strips of gravity because they score from 0 to 100. So we have mainly in the first strip mechanical problem and the last unacceptable problem. But what's happened in the mid, we have the exact rule for biotech area, speaking of monorail therapy or polytherapy. Come back to the validation. We had tried to focus to different weight the role of each factor in describing the complexity of the patient. So these are the 4 strips. Coming back to the first one, the problem is mainly major mechanical problems, so we have to improve stability. Like in the next patient, next case I would like to introduce. But before to say this, we have to point out the basic principle that nowadays we use in trauma. It means the diamond concept, developed by Tom Hainer from Boston, David Marsh from London, and Peter Janudis from Leeds. And after the 2008 in Munich, we were able, as the European Society, to develop, introducing the 5th corner, speaking of vascularization, because it's very important. Mechanical point of view, there is a premise, and the premise is about the consideration of Wolff law. It means we have to consider the spectrum of stability. So the stability given from the lesion, and from the implant, we are going to insert like a yin-yang to have a good treatment of the lesion, and we have to keep the nucleator in the lesion as well in a wide aspect to permit the healing process to come back. Also, when we have to approach a weak system, like in patient with height risk or in elderly. In this case of osteogenesis imperfecta, we had the prejudice to say it's a very difficult case, but it's not, because we wait, 24. That's the reason, because we just stabilize, we improve the stability, and we reach the healing. Or in this case, with a light infection as well, we had to improve the stability and the good healing. So we have different prejudice. When we approach this pathology, we have to consider all the aspects given from the patient. And the ladder strategy means if we have a small problem, we can give small. We have a tough problem, perhaps we have not to operate, we have not a chance to heal, or perhaps we have to improve different surgery. Speaking of the regenerative pentagon, what we mean in clinician, cell for sure, we use just stromal cells. It's very easy to pick up. Even today, my dear colleague told me new idea to use. Perhaps in the next we have some different arrow in our pocket to use, but it is very useful. And the scaffold for sure, we have different kind of scaffold because we have different pathology to treat, different cases, different lesions to treat. We have to correct, to sustain the correction of deformity, or perhaps we have just to fill a cavity, a gap. It's different, but all these, they have some peculiarities to be resorbable, osteoconductive, mechanical validity, and biocompatibility. We had this wide review in recently past, and what's new perhaps? This is aspirate of autograph. It's very useful, the RIA. This is new. But for sure, we have to use the scaffold we need, and we have to consider if the lesion has, it needs such time, more time or less time, because the resorbable of the scaffold is very critical. Growth factor. We have written a lot about BMP7. For sure, they have the only innate grade of evidence for the treatment of non-union or critical size bond defect. And at the moment, we have some problem in a few I show to you. Vascularization. VEGF, they have a role only in critical size bond defect mainly. Second strip, we have to improve the monorail therapy. Why? Because they are a low grade of a complexity, so we have to improve physical stimulation, perhaps, like in this case of septical failure, with an osteolysis, so just to put out the synthesis, we have to improve the stability, and perhaps in such a way we had use some biostimulation, and we reach a good healing. Or in this case, we can use the new therapies, the biotech. Like in this case, in a closed eye surgery, we use the cells with a good healing in this failure. So we can overlap all the traditional and all the new therapies. Perhaps the new therapies are more safety and they represent a less invasive surgery for the patient. Third strips is the more challenging for every clinician all over the world. We have traditional technique as in distraction, like this, so we can feel great gap like this. But what's new, speaking of regenerative medicine, we can avoid the second surgery at the docking point by using BMP7, this case, and cells, or perhaps introducing the new concept like masquelade technique to induce the induced membrane, the synovial membrane, where we can insert, in the second step, after we have put out the spacer, we have to improve the lengthening of the bone. And this case, it was operated 15 times before, not only in Italy with a failure. This is a very young boy. He had a good, successful heal. What's traditional again? Microvascular grafting, not very used in the lower, much better in the upper limb with a good rate of satisfaction. That in this case, with a critical size, we can use traditional microvascular graft, and then in this case to restore the prana supination and herbal prosthesis, giving a good healing. But what's new? This case I treated in very septical, very deep infection case with a critical size bone defect with sinus active. I used the 2 times, the 2 steps masquelade, and look at this. I use tradition on the radial aspect, so the microvascular graft, and when I put out the spacer, I had the anastomosis of the vessel, but look at this on the ulnar aspect that is more dangerous for the healing. I use just polytherapy. And look at this, after 12 months, early the recovery by using polytherapy. Then to the gold standard, what we consider the gold standard, the microvascular supply, and the good restoration in function for the patient. So the problem is polytherapy, because when we have to play hard, we have to use everything. But we have to know exactly what we have to use, because cells, scaffold, growth factor, we put in the same bag, but the problem is very difficult. And perhaps we have to consider what is the behavior of each of one, because we cannot for sure add all the outcome of one to the others, because perhaps we go over the 100%. The problem is they mainly act like inhibitors, and that's the reason because we develop a concept of in a while, perhaps. What's happened? Of the chamber induction technique to optimize all the aspects and to fight the inhibition. Okay, the chamber induction technique, it tries to put the lab condition in a clinical practice. All the elements of our polytherapy, they main actually in a successful way. And the chamber has to consider, it has to be some, peculiarities. It must be aseptic, it must have vascularity, it must have good mechanical stability, it must be provided with the best chance to act as a bioreactor. Look at this case with a deep septic failure. I put out in a trauma, in a tumor, and at the end, after 3 months, when I put out the spacer, look at the membrane. This is a pseudocymal membrane reactive to the semen spacer antibiotic, and I just have a gentle recut of the fragment. I insert the polytherapy. I reconstruct. I'm able to close the chamber, and look at this. I'm able to restore 2/3 parts of a humeral, and it's very new. In this case, I had a patient under chemotherapy treatment with a cancer, so it's very critical. Look at defect and the septical condition. So I had the same behavior. I cut all the lesion. I introduced the therapy, and look at this. In 9 months, it's very good, also in a patient affected by cancer. So the chamber induction technique represents a superiority versus the growth factor aspect alone. So the change in the philosophy, in the approaching, by using the new idea. This is a patient. I was in Rome giving a speech at Catholic University. They call me by phone. They say, okay, this is a 41-old female lady, and she had an accident when she was 7, and after many, many years, without a real mechanical trauma, he had this fracture. So I say, but perhaps pathological. So I require more aspect, imaging. But it is not pathological, so I treat by using the chamber induction technique and polytherapy. I reconstruct, giving stability. And at the 9 months, I noted a poor integration of the graft. So what's happened? Happened then, after 4 months, the device was failed. What to do? I put out everything. I look at the bone. It was really dead. And I perform a PET scan to focus on the necrotic aspect of the bone. And now what to do? Because she was 40 years old, very young. And I use exactly all the new technique. So I went towards MIGA implants, and it is at the beginning of my experience. Nowadays, I operated more than 130 cases, not in oncological, by using MIGA implant. And the problem is, until when we can reconstruct? What is the role of prosthesis? Because in the 4th strip of our algorithm, we have an acceptable condition. So we had to consider as well the amputation nowadays, because perhaps we have to discuss a lot with the patient. Perhaps he doesn't want to follow a calvarium in the treatment. And we have some very tough cases. This is coming from Los Angeles to my hospital. She was a champion in a motor bicycle. What to do? 35 years old. My dear friend Kaplan sent to me to operate this, and was able to operate this by using biotechnologies, and at the least she has already the fit. So we have to consider all the lesions, consider all the comorbidities. When we have cases like this, with a real distraction of the leg and ankle, we can approach by using traditional technique, but we have to consider when it's possible to do this. And when we use traditional techniques, we have as well some role also for biotechnologies to improve the rate of healing. It is very good. Like in this case, look at this feet and this ankle with a lot of holes. She was 67 years, elegant lady. She didn't accept any strong surgery, very hard, so I prefer to have 2 times by using a minimal invasive access to fill, to create the holes, and to fill by using biotechnology. At the end, I was able to perform this prosthesis, giving to her as well a good function and restoring the fit. So when we consider the new technology, speaking of research, we have to consider at the end is this, because this is the end of our pipeline of research. So we have to finalize. We have to finalize. I just finished it, so perhaps it's saying to me it's time to stop. A couple of minutes. But I prefer to complete my thinking. Okay, and as I told you, nowadays we have some new horror when we are not able to reconstruct, and we have to approach new indication as in complicated trauma, aseptic or septic like this. He was a young, after 27 surgery all over the Europe. He came to me, he was in a bed from 9 years, and I operate this, look at the functional picture after just 1 month. After 4 months, he was able to walk alone after 6 months to improve some jogging. For sure, it's not a racer, but a good restore of the function. Acute trauma like this, when we have a lot of prejudice before the lesion, because in the square you have the new fracture coming from the emergency, but we had already older lesion. And look at the knee. So she was young, very young, 32, come back to the function recovery by using these new implants. And in periprosthetic fracture like this, 90 years old, very old, with a triple chamber of septic and displays of the prosthesis and fracture. So I was able to perform this surgery, giving to her a new horizon of living. And prosthesis revision, like this, when we have no chance to restore the proximal femur because the stressing force device to this special localized part of the femur. And also in this case, we introduce the biological approach, the chamber induction technique. When we have a septic patient, we operate them, especially because we use very complex prosthesis, in 2 steps. The first, we insert the spacer, able to improve the pseudo reactive membrane, the spatial environment, able for sure to optimize the effect also of the surface. In this case, I use silver space by giving a cationic effect to realize a bacteriostasis in septic patient, and this is very useful to reduce the silver dispersion as well. What in the future? In the future, we have to prevent, and when we have cases of vascular necrosis, what to do, because we have not economic feasibility. Speaking of prosthesis, I know United States, the situation is terrible, the same in Italy. We have 160,000 new prostheses every year. We have no money enough to approach the 385,000 in the next 3 years. And the same in the United States, they are going all over the 1 million. So the problem is, what's the next future? We have to prevent, and perhaps applying these criteria, we can approach such a difficult pathology, and we can use the biotechnology, improving the chamber induction technique, the cells, and the scaffold to close the chamber with vital cells, and also in case we are not able to recover as well, we are able to stabilize the head or the femur or the knee or the shoulder or the struggle, and it works, and so we can avoid one prosthesis. And this is very new, and this is very useful. This is the OTA, American North guidelines. We present it also for the balloon technique. This is very interesting because if we have one in a vascular necrosis, we have 400 1,000 just in Italy of femoral fracture, in fragility fracture. So what to do in the next future to improve the balloon technique? It means to use the biotechnology to give more stability to the neck. Perhaps we can use just by, a minimal approach on the opposite side when we have a fracture in the elderly, or perhaps when we have a T-score or Z-score over than 4. It is very interesting. Also, in case of fracture, already we can use bad technology inserting in this special kind of screw to give a reinforcement of the neck and the head, and it is very new. This, I try to give you a general overview of the state of the art in case of orthopedic and trauma. And the membrane, they are very interested not only in orthopedics, perhaps in the cancer oncology or in other science, in other specialties. And we study a lot about the role of barrier membrane because they have to be selective to permit to work in the chamber induction technique, philosophy, all the elements giving a role in the healing processes without a dispersion. But they had to be biocompatibility, cell inclusiveness, space making, and blah, blah, blah. This is very interesting, always when we approach the case of nanotechnology. Because nanotechnology, I know my friends, he speaks in a while, so just a slide to say this is another latest horizon in our consideration. As the pharmacological therapy, we have to improve always in patient at risk, perhaps the pharmacological situation. We have to consider this. And what's new in biotech? The peptide, because the BMP7, I just finished, not more available, as in alternative, they keep being improved to give more approach to the healing processes. Gene therapy, for sure, we don't know if the BMP2 could represent a good transfer for the gene therapy. In conclusion, the more complex cases must be treated in specialized center, and when we have to approach the healthcare trend and the economic feasibility of our care, we have to consider what is the focus on osteoregenesis, because we have to use everything of our research in a rational way, giving a new setting of the new standard, already considering the patient at risk, what's new in reconstruction, in prosthesis, and how to reduce the failure rate and improving, for sure, giving a scientific evidence with studies. And these studies, they has to be confirmed in strong trial. Last, the cost analysis, it has to be conducted. The cost effectiveness of this pathology, it is critical nowadays, so we demonstrate in different papers that also we have a urn giving a good care, and it is really new. So I finish. Thanks a lot.